Yes, so we are good to go. A very good evening, all the delegates. A warm welcome on this live webinar platform, COR Connect. Myself, Bhumit from Corona Remedies. I welcome you all on this live series of COR Connect. After successful completing 6 series, today
So we are good to go.
seventh in the series, and that is on induction of labor. So before starting the webinar, let us come forward, all of us.
A very good evening, all the delegates. A warm welcome on this live webinar platform, COR Connect. Myself, Bhumit from Corona Remedies. I welcome on this live series.
See, when we are speaking, after 2 minutes, echo aa raha hai.
So it is stopped now. So once again, we are here for 7th series.
Have you sorted out the problem? Have you sorted out the problem?
Ma'am, it was sorted. Once again, I will start from the first. Okay.
छोड़ दे भाभी, क्या है?
हो गया मैम.
Let's start the academics. People are not interested in listening anything else than academics.
Sure. So we will just light the lamp first, and then we will move ahead for the academics on induction of labor. So now I hand over this session to none other than Dr. Sunita Tandulwadkar, ma'am. She is the HOD Obs and Gynec of IVF and Endoscopy Center. She is advisor and consultant from DY Patil IVF and Endoscopy Center. So before wasting much time, I think I hand over this session to Dr. Sunita Tandulwadkar, ma'am. Ma'am, over to you.
You have to make me host so I can share.
Yes, now you can share, ma'am.
Thank you. Thank you, Bhavik. So, friends, your recording is going on, Bhavik?
Yes. We are on live. Recordings are going on.
Thank you. So, friends, Namaste, Vanakkam, Sat Sri Akal, Namaskara, Shivai. Because we have a global viewership, let me welcome you all in all the possible languages. Thank you, Corona team, who is dedicatedly doing these programs, where 45 minutes we take one topic and we discuss about that topic nonstop. This is our 7th webinar, and every month on second Monday at 7:30, we come alive. Today, just give me, Dr. Rajesh, 1 minute. Sorry. So today we will be talking on induction of labor. Induction of labor is the process of artificially stimulating the uterus to start the labor. It is not risk-free and many women find it uncomfortable. So today when I'm talking about induction of labor, I'll be covering up when to do the timing, what are the various guidelines, what are the upcoming data, what are the methods we use, everything. But before that, it's very important for me to tell that induction of labor should be performed only when there is a clear medical indication for it. The expected benefit should outweigh its potential harms. As long as we are clear with this concept, the things are fine. Also, over the several decades, the incidence of induction for shortening the duration has continued to rise. And that's why this caution word I have used. Now, this I should move down. And this I'll move up. In applying the recommendation on induction of labor, consideration must be given to the actual conditions and associated condition. Remember one thing, we will be talking about recommendation, but actual what patient is presenting to you is equally important. So, slide is not going ahead. Preferences of each woman, emphasis on a cervical status of that woman, specific method of induction, what is her parity, and what is her status of a membrane. These all important thing has to be. That's why I put preferences of the woman on the topmost, whether she is willing to undergo induction. We have to understand when we talk about timing, ethnic and epidemiological differences from Caucasian population should be considered. So when we follow the Western guideline, we should know that there is some variation and we may not just blindly follow them. This is a very important way back in 1991, and I'm going to read it because it's very important. A hypothesis, therefore, is proposed that in some ethnic groups, the higher stillbirth rate and perinatal mortality may be related to different intrauterine maturation patterns, leading to a post-term or rather post-mature status in utero. Our preliminary investigation suggests ethnic prediction to early maturity, and this may predispose to the vulnerability to even mild asphyxial insult. So probably with the ethnic variation, with the Caucasian, we people, South Asian, we may be having the babies getting maturity little early. This is a very important fact. And that's why they may be vulnerable to even mild asphyxial insult at 41, 42 weeks, resulting in perinatal anoxia and mortality. Our observation revealed that fetal distress and meconium release may develop in these racial groups, that is Black and Indian, before 40 weeks. The clinical importance for the obstetrician could be that we should increase antenatal surveillance in this group and deliver them before 40 weeks. This is very important for all of us to understand that this ethnic variation may be of great value. So when we talk about timing, induction of labor is recommended. Now, what does WHO in 2018 said? WHO has recommended women who are known with certainty their last menstrual period and they have reached to 41 weeks, that is 40 weeks plus 7 days of a gestation, you can do induction. So clearly they are saying at 41 weeks. And they say that induction of labor is not recommended for a woman with an uncomplicated pregnancy with less than 41 weeks. Then 2020, this systemic meta-analysis, the review article, they supported that induction of labor for women with the post-term pregnancy. I'm not talking about up to 40 weeks. Although the evidence is weak regarding the timing, whether you should induce at 41 or 42, and for women with the hypertension and preeclampsia, in terms of improved maternal outcome, you should be. So for a woman with the premature, what is this meta-analysis saying? This is very important. Preterm premature rupture of membrane. High quality evidence suggests expectant line of management over induction of labor. And evidence weakly supports for ovulation, labor induction in women with term rupture of membrane. So if you have preterm, you please continue. Of course, you need to be taking care of strict aseptic precaution, keeping a close surveillance for the intrauterine infections, because you are thinking about baby's maturity and the baby's neonatal morbidity and mortality to decrease, but septicemia will spoil the game. While when it is a term, you can think about induction. Guidelines were consistent in agreeing that if the patient says there are decreased fetal movement, there is associated oligohydramnios, there may be a valid indication to time the induction of labor. Common indication where there was little consensus on validity or timing of induction included gestational diabetes, fetal macrosomia, elevated body mass index, and twin pregnancy. I'll be coming to it. Now, if you see gestational age at which labor starts, this is a normal labor, not induced. Mainly it is shown at 40 weeks to 41 weeks of pregnancy in 32% of the cases. In 25% of the cases, between 39 to 40 weeks it starts. This is a data which is published in 2019-20. So this is the incidence of a natural labor which happens. Now, when we spoke about WHO saying something differently, this is another interesting study, though it is in 2012, because it included 12,71,000 women with the singleton pregnancy. And they wanted to study what will happen at 37, 38, 39, 40, and 41. They have seen comparison of that. And at each gestational age between 37 to 41 completed weeks, elective induction was associated with decreased odds of perinatal mortality compared with expectant management without reduction in odds of spontaneous. So it was equally whether you deliver at 37 to 41. Though admission to neonatal unit was little bit increased when you are doing before 41 weeks in this 12 lakh woman. Now, if you see the perinatal mortality, it has a U-shaped curve towards the ending of this. This is very important for all of us to understand. So after 41 weeks, this perinatal mortality starts increasing. So 42 weeks, that is what RCOG is saying, induction. 41 to 42, ACOG says. 41, FIGO says. 40 to 41, contemporary practice, but the emerging data is coming for induction of 39 weeks, especially in Indian and Black women. This at 39 weeks. Now, this is what Cochrane in 2020. Induction of labor at or beyond 37 weeks, there is a clear reduction in perinatal death with the policy of labor induction at or beyond 37 weeks compared with the expectant management. And there were also lower cesarean rates without increasing the rate of operative vaginal. And there were fewer NICU admission with the policy of induction at or beyond 37 weeks. This is a very important Cochrane publication we should all know. But in subgroup analysis, no difference were finding for the induction less than 40, 41 to 40 to 41 and more than 41. They have found that there was no differences. So the changing goalposts are bringing forward routine offer of induction of labor from the current recommendation of 41, 42 weeks to 40 weeks of gestation in nulliparous woman aged more than or equal to 35 may reduce overall rate. So they say at 40 weeks. And a recent randomized controlled trial, RCT, published in 2016 has shown that nulliparous women aged more than 35, elective indication at 39 weeks of pregnant gestation had no significant effect on rate of cesarean and no adverse short-term outcome. So at least at 35 and above age group, they said you start inducing early. Arrive trial, which was published way back in 2018, they said that based on the finding demonstrated in this trial, it is reasonable for obstetrician to offer elective induction to low-risk nulliparous at 39 weeks of gestation. This is very important. So, induction, do they increase the cesarean? Every obstetrician who is listening, somewhere in their mind, they have faced the situation where they have asked, probably the parents were not ready, the lady was little reluctant, but maybe medical indication was needed, and that may be the reason because of PIH or diabetes you forced her to do, and they don't progress. And when you land up in a cesarean, how difficult it becomes to counsel the patient. So does that increases if patient asks you? Induction of labor in medically uncomplicated nulliparous woman at term carries more than doubling risk of emergency cesarean than spontaneous labor with no impact on perinatal mortality. All methods of induction and augmentation were associated with increased rate of cesarean, and women included in this study had no apparent medical indication for induction. They were the non-indicated cases, and they found that definitely it has increased and the caution. And that's why sometimes I feel 39 weeks is the best, because Bishop's score is good at 39 weeks than at 37 weeks. The head engagement is also there, and probably the induction duration, the latent phase, and from induction to delivery time interval decreases. At least my experience is when I go at 41 weeks induction, sometimes the patient is not ready. The meconium stent liquor, fetal distress, they are more common, and I feel for my practice, I do at 39 weeks plus. The New England Journal of Medicine, labor induction versus expectant management. Randomly, they assigned the low-risk woman. At 38 weeks induction, 38 weeks 6 days, 39 weeks to 39 weeks 4 days, or the expectant management. They divided all these patients, 3,000 here, 3,000 there. Perinatal death or severe neonatal complication occurred in 4.3% neonate in induction group, while in 5.4% in expectant management. So expectant management had more. The frequency of cesarean was significantly lower in the induction group. And that is why I thought of quoting this journal of this publication, let me see, 2018, the New England Journal of Medicine. They probably felt the induction is better. What does an induction method have to do to be called successful? When do I call that, yes, it was successful? Of course, we will call when you delivered a baby. It's as simple as that. In one line, I can say when you delivered a vaginal birth, probably unassisted, non-traumatic, very uneventful, with the good AFGAR score, without any maternal problems, then I will call it as a successful. But to make it successful, what you have to do? First is, well begun is half done. You see to it that Bishop scoring system assessment you have done. Make this checklist of your patient and tick mark, is she fit for that? Other predictive method, ultrasonography, should be studied. Checklist should be documented, and gestational age, indication, and consent. This is for your own safety. Also, 20 years of your practice, you want to analyze your data, it will be so easy for you to do. The favorable Bishop score, for 8-year-old, we are using Bishop score, and this is a modified Bishop score, which also consists of the cervical condition as well as the head engagement. And if better the Bishop score, more better will be your induction. What should be the end point of induction method? Cervical score and changes. When you are checking every time, it should show the improvement in cervical score. Onset of active labor, yes, that means I have induced better. Need for using another agent for augmentation, I might have induced, I probably might have used other drug to augment the contraction and the vaginal delivery. This should be our end. Now, what are undesirable outcomes? We all desire for a normal vaginal healthy delivery, but what are undesirable? This is the Cochrane collaboration. They said vaginal delivery not achieved within 24 hours. That is little bit upsetting for both the obstetrician as well as patient. Hyperstimulation with fetal heart changes. Requirement for a cesarean section, again undesirable. Serious neonatal morbidity or even the perinatal death, absolutely undesirable. And serious maternal morbidity or death, another undesirable. So we cannot afford to have anything. So what should be the ideal agent I should be taking? The ideal agent must effectively induce the labor and convert unfavorable cervix to one receptive to delivery. So agent should be effective, safe. It should have control over release pattern and the degree of a cervical ripening. Ideally, a single dose with reduced examination. may help to reduce the need for oxytocin augmentation. So you started for induction and itself has given a good strong contraction that you did not need augmentation. It should be acceptable. The method should be acceptable to the patient. And drug administration can be stopped by insert withdrawal at any time. That should be beautiful. The moment you feel tonic uterine contraction, FHS getting accelerated, decelerated, you should be able to control. And the cost of induction, those drugs should be reasonable. So these are the various methods: non-pharmacological, surgical, membrane stripping and amniotomy, and mechanical, transcervical balloon catheter, especially when it is a non-favorable cervix and medical indication to induce the labor. So these are various mechanical and pharmacological for induction and augmentation, oxytocin. For cervical ripening or labor induction, prostaglandin E1, prostaglandin E2, either gel or the tablet, or dinoproston intravaginal gel or the vaginal pessary, both. So these are the various. Let's see in hypertensive disorders of pregnancy. Let's see one condition indication. In women with preeclampsia or gestational hypertension, beyond 34 weeks, elective delivery can decrease the incidence of complication, severe hypertension, and the need for anti-anticoagulants. Remember one thing, you may be thinking that I started the patient drugs and BP is under control. But remember, the pathophysiology, which has set inside, is going to go progressive. And that's why we do regular blood checkup of the patient. We do coagulation profile. We do their liver functions, creatinine. All this is why important the uric acid is, because the changes can keep on happening. And sometimes you may feel, especially IVF conceived, especially obese or PCOS, when we know that it is going to progress further. For women with preeclampsia, induction should be planned at 37 weeks or earlier if indicated for maternal or fetal compromise. And for women with gestational hypertension at low risk of adverse outcome, expectant management can be considered beyond 37. She don't have only little bit blood pressure rise, but she don't have urine albumin. If you feel the patient is reliable for follow-up, she don't have excessive weight gain during pregnancy, she don't fall into the category where immunological positive or low PAPA or IVF PCOS, then you can think about those low risk adverse outcome patient for a continuation beyond 37. What about diabetes in pregnancy? The management of it should be individualized. There is no standard protocol. In women with gestational, without other maternal or fetal conditions, no difference was detected in birth outcome regardless of the approach used. That is 38, 39 weeks versus expectant management. So if diabetes is very nicely under control, they can be treated as other non-diabetic women. But induction of labor is not recommended before 39 in a woman with well controlled on only diet. She doesn't need any antidiabetic. So it is just that she has a little bit raised sugar, you should not be. But induction of labor is recommended at 38 weeks if diabetes is controlled on insulin or maybe metformin. Fetal growth restriction in IUGR patient, FGR, what are we doing? Induction of labor at term is advisable to prevent the stem birth, but the timing is guided by the severity of fetal growth restriction and a deterioration in Doppler parameter. So depending upon the severity, again, you need an individualization, and depending upon the severity, the Doppler changes and the associated why the FGR is happening, depending upon the condition of it, you need to do very close, intense monitoring, and you may deliver them depending. Twin pregnancy, this is very important. You cannot dream of taking twin pregnancy to 40 weeks of gestation. Forget about anything. The mother, she will be so uncomfortable, physically impossible for her to come out of the bed and go. All the time, bowels are so badly compressed by this distended uterus that her diet is going to be so low. So uncomplicated twin pregnancy, when there are no contraindications to vaginal delivery, induction may be desirable at 37 weeks. Contraindication to the twin are monochorionic twin or first twin in a non-cephalic. Early birth at 37 gestation compared with ongoing expectant with uncomplicated dichorionic twin does not appear to be associated with increased risk of harms. Intrahepatic cholestasis, again, it depends. Can be considered between 37 to 38 weeks. An earlier induction may be warranted in cases where there is a presence of severe biochemical abnormalities, especially severe derangements of the bile acid levels also. You may think of before it becomes deteriorating, before liver function deteriorates so badly that it affects the coagulation profile also, and it will lead into the cascade, you probably may induce them. So intrauterine fetal demise, this is very challenging. Whether you should be waiting for the natural labor pain to come, continue the expect management. When patient is psychologically built up to continue, you have to think that the lady is carrying that dead baby for a long, whether she is ready for a coagulation profile, but her cervix is not favorable and you are in a trouble. Whether I induce and if I fail, I might have to land up in delivering by cesarean for an intrauterine demise. Any intervention of amniotomy or anything you do, you know that with the IUD, chances of infections will be high. So the woman and her partner should be supported and counseled to cope with the situation. She should be offered a choice of immediate induction of labor versus expectant management. We should be talking to her and telling her pros and cons of both. If I do expectant, what will happen? And if I do induction, what can happen? However, in presence of sepsis, preeclampsia, abruption, there's no question that we need to plan. Although most patients will desire prompt delivery, immediate delivery is not critical. In more than 90% of the women, labor starts spontaneously in 3 weeks of diagnosis, and DIC is reported in 25% in women with the dead fetus for more than 4 weeks of pregnancy. If induction is delayed for more than 48 hours, she should be having a testing for disseminated for a DIC twice a week. For induction of labor, prostaglandin E2 and oxytocin will be used. That I'm going to cover. Now, another challenging situation we face is a previous cesarean. These are the various indications, and when should we do, I'm discussing with you. So previous cesarean, whether we can do the VBAC. The essential prerequisite for induction of labor in women with previous is the availability of facilities for maternal-fetal monitoring and emergency cesarean anytime we feel threatened rupture, whether you have the facility. A detailed review of the patient clinical profile should be done to ensure the eligibility. So what was her indication in previous? What was the weight of the baby? Am I very sure that if she gets a very good contraction, she will deliver? It is a non-recurrent cause for so that I can avoid second cesarean. Counseling should be done, conveying chances of vaginal delivery and the risk of rupture with the use of various agents. In general, at least 60% of the induction results in delivery. This we have to tell the patient. 60% will result in normal delivery, but that maybe the number may much be higher in women when the favorable cervix and prior vaginal delivery. So this is very, very important that we explain to the patient. Now, this is very long slide, but I want you to all read. In 2017, the Cochrane said, elective versus repeat cesarean versus induction of labor. What does the Cochrane says? Very interesting. What is the issue? When clinicians believe that intervention is needed in a pregnancy, which is a better option for a pregnant woman who has had one or more previous cesarean, a planned cesarean section, or a planned induction of labor. Why is this important? Because risk and benefits are known to occur with repeat elective section as well as with planned induction. However, we don't know whether the evidence indicates that we can expect better outcome with one form of a care over the other. And studies so far have had strong potential for bias, which means that the results may not be reliable. So what evidence does the Cochrane found? They found no trials for this time. There were no trial that this lady will go for a cesarean and that this lady will go for a channel. There were no. So what does this mean? When there are no trials done by Cochrane, says there are no trials done, what does it mean? Caregivers and the woman faced with a making decision about labor and birth after a previous cesarean cannot be informed by any randomized trial evidence. Woman should discuss with her caregiver the benefit and risk of both the course of action. And she and the caregiver should come with the shared decision for what action which is best, mainly on the woman's wish and priority along with obstetrician's decision. So there is no consensus. It is always the caregiver and the woman. They have to come to the common decision. In women with the favorable cervix, amniotomy followed by oxytocin infusion is advisable, while in women with unfavorable cervix, use of mechanical method like transcervical Foley's catheter is a preferred method of induction. I'm talking about previous cesarean. And then once the contraction sets in, amniotomy and oxytocin. Use of prostaglandin is contraindicated in women with the scarred uterus because of a high risk of uterine rupture. Although the chances of uterine rupture are increased with induction, the absolute risk is still reasonably low. So don't be so scared also. Now, in other cases where there is a preterm premature rupture, next indication. So we saw from preeclampsia, gestational diabetes, postdatism, FGR, previous cesarean. What about the preterm rupture of a membrane? If preterm prelabor rupture membrane occur after 34 weeks, the plan for induction can be made after discussing with the woman the risk of sepsis to the woman and to the baby and complications of preterm birth and availability of intensive. This has to be balanced. If preterm pre-rupture membrane occurs after the period of viability, induction of birth should not be carried out before 34 weeks. Try to give a conservative management, but you ensure that there is no chorioamnionitis. That because we all know that rupture membrane, most common cause is chorioamnionitis. So you ensure that there is no, take a vaginal swab for culture, see other parameters, see her pulse, see her WBC count. So everything has to be. Sometimes you're putting your finger when you are taking a vaginal swab, hot vagina itself, you can feel that. Okay. So antenatal steroids and antibiotics should be administered immediately. Maxen, of course, as a neuroprotective if before 32 weeks, but tocolytics are not indicated. Always remember the labor contractions start when it is a feto-maternal circuit. It is the fetus who gives the signals for starting the contraction. So if the baby is not well in the utero atmosphere, baby will start the contractions. So never do tocolysis because you may hide, you may underestimate the fetal condition. It may be given to delay the effective steroid occur. Now, what are the contraindications? We are talking about all indication. Induction should be avoided if you find placenta or vasa previa, umbilical cord presentation, transverse life, footling, prior classical or inverted T uterine incision. Significant. This is very important. Sometimes, very rarely, you may land up in inverted T uterine incision. Then on that discharge card, you should be writing very clearly that next time she should be for elective cesarean. Trial of labor cannot be given. Write in a discharge card, patient may lose the discharge card. So inform to the family, inform and educate them. Significant prior uterine surgery, full thickness myomectomy, transfundal uterine surgery, you may avoid vaginal. Active genital, but if your myomectomy was where the cavity was not opened, you may think of vaginal. Active genital herpes lesions, pelvic structural deformity causing CPD, invasive cervical carcinoma, previous rupture, previous pelvic surgeries of fistulas and pelvic floor repair, all we should be taking. Now let's talk about methods for cervical ripening and induction of labor. Let's talk prostaglandin E2, the most favored by many. Prostaglandin E2, dinoproston, is available in two forms in India for ripening. Dinoproston gel, that is 3-gram gel, 0.5 milligram of dinoproston is placed inside the cervix, but not above. So when you put the gel, it should be intracervical. The application can be repeated after 6 to 8 hours, but not to exceed 3 doses in 24 hours. Dinoproston vaginal pessary, 10 milligram embedded in a mesh, is placed in the posterior fornix of the vagina for 24 hours. Now, this has been associated with risk of uterine tachycystole, higher rate of choriamnitis in setting the ruptured membrane. The use of vaginal and intracervical dinoproston may not be very effective in women with ruptured membrane. Both forms are found to have equal, whether you are using gel or a pessary. Both result in significantly lower cesarean and increased vaginal delivery within 24 hours. Vaginal preparations are easier to administer than intracervical preparation. Intracervical dinoproston gel. Let's talk about gel first. The gel, it should be stored between 2 to 8 degrees. This is very important because you have a different degree for a pessary. The application can be repeated in 6 hours, but not exceeding 3 doses in 24. Ambulation is allowed 30 minutes after the insertion. Temperature, pulse, respiratory rate, blood pressure, uterine activity, vaginal bleeding, all should be monitored after insertion and then 4 hourly. If necessary, oxytocin for augmentation of labor is started only 6 hours after the last dose. So if you felt that a mild irritable uterus has become, but you have put only 2 hours prior, don't be in a hurry to start the oxytocin. Wait for 6 hours after the last dose before you start the oxytocin. Now, what about the pessary? It has to be maintained in a freezer, -10 to -25 degrees. It should be placed transversely in the posterior fornix. It releases the PGE2 at a constant rate of 0.3 milligram per hour over 24 hours. Ambulation can be allowed as after 30 minutes. Monitoring at frequent intervals for a contraction and yeast can be used. It is removed at the end of 24 hours, a dosing period, or once the labor has been activated. Rupture of membrane after the insertion of pessary does not necessarily remove. You need to remove the pessary. Let it be, even the membrane has ruptured. It can be easily administered. That's an advantage, and quickly removed. This is another advantage. If you feel that tonic contraction has started, just put 2 fingers, take out this pessary. Oxytocin for augmentation, if necessary, started 30 minutes after the removal of the pessary. So if you feel that patient has gone in active labor and you feel like you want to augment with the oxytocin, remove that. Don't keep the pessary. Wait for 30 minutes and then you can start the oxytocin. Now, comparison. Case match studies, though the number of the cases are less, 38 cases with the pessary and the gel. The indication was more or less the same. Primiparity, both have more or less the same. Now, what does the result? Did not pursue or get uterine activity, not a single in pessary group, 6 in gel group. Repeat installation needed in 3. Same pessary they have introduced. But in 15 cases, they needed, in 1, they needed more than 1 dose, and in 2, they needed more than 2 doses. Baseline Bishop score was better with the gel. Now, this is very important. Oxytocin augmentation in pessary only in 8 cases needed, while in 18 cases it is needed. Meconium, 5 with the pessary. Meconium and CTG abnormality was a little bit on higher, while caesarean birth rate was 39% in pessary, 50% in the gel group. Birth weight, more or less, they were same. Now, caesarean, if you see the indication for a pessary, not a single was failed induction. Everyone set into the contraction. Non-progress of first stage, non-progress of second stage, meconium liquor, or abnormal CTG were the main indication. While in gel, non-induction of labor was in 6 cases. Labor and delivery negative outcome. Neonatal resuscitation, nothing, and ICU transfer, nothing. More or less, they had the same. Labor and delivery timing. Here, there is a tremendous difference. If you see first perception, 4.3 hours, while here it is 6 hours. Time to uterine activity 6 hours, it was 9.6 hours. Time to delivery was 9 hours, here was 16 hours with gel. So probably when we put the gel for augmentation, you need to add on some other drug. Time for induction to declaring that non-progress, 13 hours, here 15 hours. Time for induction to declare failed induction, not a single case in pessary, while 6 cases in a gel. So in conclusion, the favors the use of dinoprostone pessary, avoid failure of induction, better Bishop score, and shorter timeline to normal delivery. No difference found whether epidural analgesia returns, maternal or neonatal. Probably I will write cesarean because cesarean was little higher in other group. Favor the use of gel, not having freezer, because this pessary you have to put it at minus 10 to 25 and the cost that goes in favor of a gel. Now prostaglandin E1, misoprostol. Misoprostol regime are dose-dependent and require multiple divided doses. Oral route may be favorable as compared to vaginal, but we all do now vaginal, though this was Cochrane data of 2010. So no more we do. 25 microgram every 4 hourly is equal to dinoprostone. At higher doses, effectiveness is slightly increased, but hyperstimulation rate also is more. Balloon devices, Foley's catheter, as I said, previous cesarean, scarred uterus, transcervical, it is safe, maybe cheap, maybe easy to store. I think those who are very senior, they have used it very much, especially in the scarred uterus or unfavorable cervix. Put it and dilate, and either you remove it after 24 hours or 48 hours, or it will fall on its own when the uterine contraction and dilatation starts. It causes less uterine hyperstimulation compared to prostaglandin, but does not reduce the cesarean rates. Balloon catheter and vaginal may have similar effectiveness. A smaller degree of traction you should be keeping on the patient's inner side of the thigh. It should be left until it falls out or 24 hours. Foley's catheter followed by oxytocin infusion is recommended as an alternative method for induction. So 24 hours you kept it and then you did not find it, start oxytocin. It is contraindicated obviously in placenta previa, rupture membrane or undiagnosed vaginal bleeding. What about the low-dose oxytocin infusion? The low-dose regimen for cervical ripening begins with 1 to 2 milliunits per minute and increase incrementally by 1 to 4 milliunits at every 30 minutes interval. So now how do you calculate this? This is the chart. You want to take photograph, you can take. So oxytocin infusion, you add in 500 ml of relactate. 1 ml is equal to 16 drops. So how do you measure? 8 drops is equal to 1 milliunit. If you put 1 unit of this. If you put 2 units of oxytocin, 8 drops will be 2 milliunit. Equally, 16 drops, 2 milliunit, while here 16 drops, 4 milliunit. So when you want to start 4 milliunit, start 2 units of oxytocin with 16 drops. You want to start with lower dose. You want to start with 1 to 2 milliunit for cervical ripening. You may start with 8 drops with 1 unit only. So this is very important for all of us to know. Oxytocin versus prostaglandin in PROM at term. Whether you will use gel, oxytocin, they all are equally effective with term. However, duration of delivery is longer when you use only oxytocin. So prostaglandin definitely helps to decrease the duration. This is a SOGC guideline. What about the prostaglandin in post-date induction? This is in a PROM. In post-date, they increase the chances in achieving the prostaglandin better. Oxytocin induction may increase the rate of interventions in labor. So prostaglandin seems to be superior in these cases. Membrane sweeping. Many of us have this habit. At 38, 39 weeks of pregnancy, it's uncomplicated. Patient is not much ready for induction. We do the internal checkup to see even the pelvic assessment. If the find that the cervix is allowing your finger, you always have a habit of putting and sweeping out the membrane, because these membranes, then there will be a release of the prostaglandin we will set. So if patient is not ready, we do it many. It solely improves the rate of entering into the spontaneous labor. It does not improve any maternal or neonatal outcome. It is suitable for non-urgent indication for term, because interval between sweeping and initiation of labor can be longer than other methods. So when patient says, I'm not ready, that is the method I go for. At 39 weeks, she is not. Second thing, you try to, another thing I always do is, even if I have to do pelvic examination for a pelvic assessment, I will always do on Monday, Tuesday, because invariably I find that 3 to 4 days later, whatever care you have taken, aseptic precaution, patient invariably comes with rupture membrane, and you land up your weekend spoiling yourself. Anyway, this is out of the context. I'm just giving the tips. It is suitable for a non-urgent indication, sweeping, as I told you, not ready for induction, and you feel that 39 weeks, it's nothing to worry about it. She's 34 to 36 weeks, 35 years. I might as well just do sweeping and send her home. I know within 24 hours or 48 hours, she may come back with the contractions. It can be done simultaneously at the time when you assess the cervix after informing the patient. It can be repeated if labor doesn't start spontaneously. It's not that you sweep and she did not, and she comes for a follow-up. You cannot do. You can again do it. Membrane sweeping definitely reduces the number of women having formal induction of labor for post-it. Definitely it causes a discomfort patient. She's a pregnant lady, and sometimes what is problem with sweeping is irregular contractions, vaginal spotting, bleeding. Patient comes with the unscheduled visits. Irregular contractions. She just says, I get one contraction in 1 hour. Then she says in 2 hours. So it doesn't set you with the regular contraction as with the other methods. This study demonstrate that membrane sweeping is effective in promoting the spontaneous labor, reducing the need for an induction. So sweeping is to reduce the need of induction. The result of this review suggests that the effect is significant from 38 weeks and is not dependent on number of timing of membrane. So usually it gives a good result only. Otherwise also your finger you need to add in a priming only after 38, 39 weeks. When the head has gone really very good, you may find open cervix. There is no evidence supporting any increase in maternal fetal morbidity, suggesting it is a safe method. We recommend, therefore, that there could be a reduction in gestation at which membrane sweeping is offered from 40 weeks for a priming and 41 weeks for nulliparous to 38 weeks onward for all risk women without any increased fetal morbidity or maternal morbidity. This may result in decreased need of induction. And I'm sure many people, they follow this in their practice. Amniotomy. A simple, effective method when membranes are accessible, cervix is favorable, Paris lady, 39, 40 weeks of pregnancy, open hours, you can just do, provided the head is engaged. Flow of amniotic fluid should be controlled with your vaginal finger. The liquor should be drained very slowly. Sudden decompression can cause an abruption. Care should be taken when amniotomy is done in unengaged presentation, because there is a risk of cord prolapse. And the vaginal finger should never be removed until the presenting part resets against the cervix. So don't just rupture and come out. First is allow the leakage very slowly. Second, ensure that the presenting part has been fitted on the cervix. Alone, it is never recommended for induction. When you do the amniotomy, you have to start oxytocin along with it immediately after or within 2 hours, depending upon the contraction intensity. Amount and liquor of the liquor has to be observed. Monitoring of the fetal heart is done during the procedure. Non-medical methods, acupuncture, breast stimulation, castor oil, sexual intercourse. I cannot go in detail about this. Method of induction, systemic review in 2018. Why I'm saying here is prostaglandin E2 and vaginal misoprostol were more effective than oxytocin, bringing out vaginal delivery within 24 hours, but were associated with hyperstimulation. Mechanical method of uterine hyperstimulation compared with the PGE2 and misoprostol, but increased maternal and neonatal infection morbidity compared with other. Membrane swimming has reduced definitely the post-term gestation. Why were we looking for a change? When induction of labor is established for so long, why are we looking for a change? Routine practice before 2018 was to use a gel intracervical or intravaginal. The issues we were facing was a failed induction, reinduction, maternal perception of not going into labor at all, non-availability of the legacy brand. Oxytocin, we were concerned about its efficacy. For 24 hours, 48 hours, contraction are not, and it becomes such a difficult situation to face the relative when you were using only oxytocin for induction before the era of prostaglandin. And it was very difficult to explain why we induced. Misoprostol concern about over efficacy, hyperstimulation, and that's why we are looking. So what to use? Vaginal prostaglandin E2, gel or tablet is the preferred method for induction of labor unless there are specific clinical reasons for not using it, especially when you have risk of uterine hyperstimulation or patient has another contraindication like previous any other contraindication which is not allowing the prostaglandin gel, maybe low-lying placenta or bleeding or patient having the COPD or any other reason where prostaglandins are contraindicated. Otherwise, vaginal prostaglandin E2, gel or tablet is the best form. Monitoring, of course, you need to this. Maternal as well as fetal. Before induction of labor, NST is recommended. Very important. Do the NST. Confirm that all is fine before you start. Intermittent maternal and fetal heart rate monitoring should be done every hour initially. Continuous electronic monitoring, frequent intermittent heart monitoring, whatever it is. Once she goes in an active labor, it should be little more aggressive. And progress of the labor should be monitored with the partogram. Close watch is kept for the temperature, pulse, blood pressure, fetal heart rate pattern, vaginal bleeding, hyperstimulation, uterine rupture, scar dehiscence, all this. So when you do the induction, you definitely invite yourself more close monitoring of the fetus as well as mother. Remember this. Pain relief, of course. Women should be informed about the availability, but many a times you should be telling, especially when you are doing an induction, please teach her breathing and relaxation. Because suppose she started contraction, she is in a latent phase. You put the epidural, you engage a team of epidural for a monitoring with the patient. And sometimes it may land up in 24, 48 hours monitoring, especially the patients who have a low pain threshold. So you tell them, once you go in active labor, I will do the pain relief. Till that time, breathing technique, relaxation, or a tramadol MZ drip can be given. If regional anesthesia is planned, the woman should be informed about the risk and benefits and implication. Sometimes you may need a little assistance in second stage. There is no need to wait for labor analgesia arbitrarily till the cervical dilatation has reached to 4-5. If given early, it does not affect the progress, but you engage the epidural person. Complications of induction, uterine hyperstimulation. So first you discontinue the infusion, withdraw the pessary if you are using. Tocolytics, preferably beta-mimetics. You can put the nasal spray also. Contraindications of beta-mimetics, especially cardiac disease, should be kept. So when you are inducing prostaglandin, remember you cannot do this. If associated with abnormal fetal heart pattern, delivery has to be accomplished with a cesarean. Rupture uterus, so patient should be closely monitored. Close watch is kept on the maternal and the fetal sign. Failed induction. One has to understand when should we call. Don't be in a hurry to call failed induction. You may allow the latent phase for 24 hours or more. Failed induction of labor must be differentiated from failure of labor progress. Very important. Subsequent management is another attempt to induce with a different method after discussing with the couple, but it also depends upon the nature and urgency of clinical situation or the cesarean delivery. So counseling of a woman for planned for an induction, information should be provided and her partner with the process of induction, the woman should be given enough time to ask the question. Induction of labor is a huge counseling process and it should include all these. You have to explain why are you inducing, what are the risk of induction, what are the benefit, what is the way, what is the expectant duration of a labor you are expecting. All that you have to talk with. Outpatient, there was no extra benefit from this approach. I feel only when I do the sweeping I will allow outdoor. If there are people who have done this misoprostol induction, they have to understand that it may lead a little bit in trouble on an outdoor basis. Induction of labor, clinical predictive factors are this multiparity and a high bishop. So if I have to conclude which patients are favorable, multiparous and a high bishop score at the beginning of induction, where the protective factors for a vaginal delivery. While age above 35, fetal birth weight more than 3.5 kg resulted in risk factor for a cesarean. So Bishop score gives tremendous importance. If it is a posterior, high up cervix, head not engaged, long, firm, you have to understand this is unfavorable. Woman experiences, if this is a very interesting publication, so I felt like showing you before I conclude. In 2019, woman's experience of induction of labor, the qualitative systemic, the review indicates that it is a challenging experience for women, which can be understood in terms of the gap between the need and the reality of their experience concerning information, decision-making, support, environment, good quality, appropriately timed information. You need to have a team who will do this work for you. You cannot be just single-handedly managing everything. And you need to have a compassionate support for significant others than the healthcare provision. So it's very important, and the experience was. So friends, every lady has the right to enjoy her parturition. Don't make it uncomfortable. As an obstetrician, our job is to ensure that this happens. She enjoys her parturition as much she enjoys her pregnancy and holding the baby all together. It is our ethical responsibility to make it for the betterment of a mother and a childbirth. If you are doing an induction, you yourself should be asking for my daughter-in-law, for my sister, whether I would have done this. If I would not have induced, then please don't do for that patient. Friends, before I end, I just wish to tell you, first of all, thank you for your patient hearing. And also, please bless me. I'm going for a Foxy presidential elections. It will happen in September 2023. Please support me and bless me. Thank you so much. If you are doing endo, ART, high-risk prosthetics, stem cells, unless you have a good team, you cannot achieve anything. Thank you so much for your patient hearing. Thank you. Team Corona?
Yes, ma'am. So once
Are
again,
there any questions?
at present, we are not receiving any questions.
Fine. So we
Yes.
can conclude, and it will be available on a YouTube, and later we will circulate the links also, right?
Yes, yes, yes.
Thank you, Bhavin. Thank you so much.
Thank you very much.
I know you people have to hear so much for 1 hour.
No, we are here for you anytime.
Bye.
Yes.
We'll
Yes.
meet on second Monday, 1 month,
Sure.
7:30 p.m. again with yet another topic we'll declare.